go on to my talk, which is going to be optimizing outcomes with premium IOLs and managing refractive surprises. We would try our best to deal with your questions if time permits. We look forward to a lot of audience participation, which is how this whole session is going to be of a value addition to all of us. So, my talk, the first slide has been very beautifully explained by Dr. Ramamurthy, that is today patients not only want uncorrected vision for all distances, but they demand a quality of vision and something which would get them up and about the very next day and a permanency in this vision. So then there are certain challenges which are inherent. Essentially, there has been always a thought in our minds about the previous generation multifocals and how they have performed, but there has also been an increasing knowledge that there is a lot of change which has come in the technology as far as multifocal lenses are concerned. So the surgeon needs to keep this in view when he sits across with his patient. But what has been interesting is that the patients have come to understand that there has been an evolution in the technology and they are very receptive to this change. So we need to work out the best balance, give that extra chair time and ensure that we have satisfied patients with a satisfied visual outcome. I would be categorizing my talk in these different sections, which I'm sure is seen by all of you. So the careful patient selection, how you're going to be counseling them and how you need to evaluate right from the anterior to the posterior segment, how to ensure that we give them emmetropic outcome, which naturally mandates that the surgery is absolutely meticulous. The post-op care also has a role to play, and of course, how the modern technology has added strength to all of this. When we talk of pre-operative counseling, what we need to clearly tell our patients is that the dependence on glasses is definitely reduced, no doubt, but there is an associated glare when we are talking of these premium multifocal patients. So we need to explain to them that a bilateral surgery would be the way to go. If there is some residual refractive error, a touch-up procedure might be needed, which should be done, which should be promised, and we need to explain to them that a neural adaptation is always there, which is going to come to our rescue. It is something more effective in the younger patient, but definitely a wait of up to 1 year should sort them out in most of these situations. The next category we need to talk to them after the counseling is that we need to understand that the problem has to be clear and safe from the ocular surface to the retina. In other words, we need to pick up those red flags which could be there in the whole track and ensure that these red flags are not included, those kind of patients are totally excluded when we are planning a premium IOL implant. It could be something as basic as a pre-existent dry eye disease which has been missed, which has to be looked into and treated. It could be a dry eye which has got triggered by the cataract surgery itself, some kind of a smoldering inflammatory process, or the medications which has disturbed the ocular surface. So we need to treat the cause before we take up these patients for a premium IOL implant. We need to treat them with artificial tears. We need to keep them on immunoregulatory agents which should address the inflammation, which is a long-term one. We need to use punctal plugs to conserve those limited tear production which is there in this older generation of patients. Sometimes a week or two of treatment of topical steroid drops ensures that low-grade inflammation is totally dealt with. Some of these patients need a more aggressive treatment for the myomitis with lid hygiene, and even a course of oral antibiotics would definitely help them through. We need to keep in mind that there are certain retinal disorders which could be something as simple as a maculopathy from a diabetic disease or a early epiretinal membrane or any old vein occlusion. It could be an ARMD which is evolving, a lamellar macular hole. Any of these things could have an impact on the final visual outcome, and we definitely, an OCT is absolutely mandatory when we are considering a patient for a premium IOL implant. I would say with the present day information of on behalf of the patients, we owe it to practically all of them to do an OCT to rule out these problems or explain to them what is going to be their final visual outcome. As far as ensuring an emetropic outcome, we need to be sure that we do an accurate biometry, and which is something very feasible with the latest generation formulae which we have for a IOL power calculation. We need to understand that amount of astigmatism is taken into account, and we suggest the right kind of premium IOL for these segments. If there is a residual refractive error, it definitely needs to be treated once the eye stabilizes, and we need to ensure that we are examining these patients on more than one modality if it is possible, to realize that we have achieved the right kind of optimal evaluation. I am not saying that the immersion biometers have gone out of the market. They have a very major role to play, but if you do have an access to the optical biometers today, it is a definite step forward which brings in a greater promised accuracy. We need to keep in view that the increased the frequency at which the laser beam falls in an optical biometer, and how as against an A scan, wherein it detects more of the paramacular and the macular region, and there is a little variability with the optical biometers. There is a precision with which the light falls on the fixation point. So, in fact, the difference is about 200 microns when you are measuring with the immersion biometers and the optical biometers, and this has to be factored in if we want the most optimal results. You can see there are an array of technology which we have at our doorstep. We have different kind of keratometers, topographers, eye trace and more. What is most important is we need to be also clear that the anterior surface, the topography of the cornea is a regular topography, and if it is an irregular topography, these patients would not do optimally with a premium IOL implant. Again, if we have access to eye trace, it will be able to tell us whether there are more abrasions in the cornea, and this again would be not very acceptable for a premium IOL implant. When you are doing a keratometer, you find there is a discrepancy in your results when you are measuring on two instruments. Rather than getting flabbergasted over it, I would advise that you immediately think that there could be something there on the ocular surface and treat the ocular surface, and then when you go back to taking your measurements, you find that you are more bang on in your evaluation. There are different kinds of keratometers and topographers which are there in the market today, and what we also need to know is each of these are measuring at different distances from the central point. So, and the keratometric index is variable. There are a lot of paraaxial assumptions which come into play, and the most accurate way of measuring is measuring right onto the center of the cornea, which is not possible. This becomes even more challenging in a post-refractive surgery eye, wherein the central cornea becomes oblate or it becomes too prolate. When it comes to measuring the next factor, that is the astigmatism, today with the amount of knowledge explosion which has occurred, we have come to understand that we need to factor in the posterior corneal astigmatism. We need to understand what is the role play of surgical induced astigmatism, which had a very major role as far as astigmatism was concerned earlier on. And we also need to know what is this toricity ratio which has to be factored in to get the most optimal results with the toric IOLs. So, what we now understand about the posterior corneal astigmatism is that the posterior cornea is steeper vertically in 90% of the cases, and this induces a power horizontally. In other words, on an average understanding, like if the anterior cornea is with the rule, the posterior corneal astigmatism is roughly about 0.5 diopters, and if the anterior cornea is against the rule, it's on a rough understanding, the posterior cornea would be 0.3. But we need to have ways of actually measuring it, then going on with these average values. So, for this, Pentacam, the Galilees have all come into gaining some stand, but all of these need to be yet perfected. and as far as these are concerned, the Baylor's nomogram with its population average values and the Barrett's seem to have a greater understanding, greater value. Today we have the IOL Master 700, wherein you are able to do what is called a measure of a total keratometry. In other words, you are able to measure the anterior corneal surface and the posterior corneal surface without having a mathematical model derivation of the posterior corneal astigmatism. The measurements here are done in 3 zones, which is called as telecentric keratometry. There is also a swept source B-scan measurement which is coming into play. In other words, there are 3-dimensional measurement wherein you are able to get the accurate corneal astigmatism on the anterior corneal surface and the posterior corneal surface, and then a newer formulas or the Barrett total K or a TK universal 2 has evolved, the Barrett TK toric which has been evolved, which gives us even greater promised accuracy. What is this role of surgical induced astigmatism? If you now measure the values, enter the values of the amount of astigmatism or the magnitude and the axis of astigmatism on a double centroid plot, you find that in most eyes which have the incision is 2.4 millimeters or less, the actual magnitude of astigmatism is all only about 0.1. In other words, all our earlier measurements of surgical induced astigmatism needs to go into the dustbin. The other important thing which has surfaced is toricity ratio. We all know that the amount of astigmatism on the corneal plane is actually being addressed with the intraocular lens placed on the IOL plane, and this on an average, the average of the astigmatism on the IOL plane to the corneal plane in an average eye has been found to be 1.5. But if you were to assume on this fixed toricity ratio, it would be like assuming on a fixed effective lens position for a spherical IOL power calculation. We are all familiar that the effective lens position changes based on the anterior chamber depth, like it could be more in an eye which has a deeper anterior chamber or less in an eye with a shallower anterior chamber, which could have a correlation with the axial length, but there are a whole lot of variables here. So by assumption of an average pseudophakic eye or an average toricity ratio, therein creeps in some kind of an error, because we need to be cognizant of the fact that if the IOL is even sitting a little posteriorly in the capsular bag, the IOL power needs to be a little higher. So there are so many variables which come into when you are actually trying to address astigmatism in its totality. So Savigny et al. Came up with this table wherein he plotted on the function of axial length to corneal power that if an individual had an axial length of 20 and a corneal power of 38, the toricity ratio is actually 1.29. Whereas if an individual has an axial length of 30 and a corneal power of 48, the toricity ratio goes to 1.86. In other words, the toricity ratio could vary anything from 1.29 to 1.86, and imagine the amount of error which would trickle in if we were to just assume a fixed toricity value. In fact, a shorter eye and a flatter K would end up getting overcorrected, and a larger eye and a steeper K would end up getting undercorrected. So the need of the hour is for us to understand and evaluate every single data in its complete precise values. So now we have the different toric calculators of the different IOL manufacturers, which account for the posterior corneal astigmatism, the centroid value, the effective lens position, and the toricity ratio. In fact, the Barrett's toric calculator, what it does is, it uses the effective lens position from the Barrett universal 2 formulae and uses a mathematical model to calculate the posterior corneal astigmatism. The AMO calculator also has a way of a nomogram to calculate the posterior corneal astigmatism, and it uses the Holiday 1 formulae for that. So we need to understand that a whole lot has come in evolution. Different IOL manufacturers have arrived at different ways of addressing these very essential factors to ensure that we get premium with our toric IOL implant. This is something which we need to always have in mind, that topographer has a very important role, and the corneal topography is irregular, is ideal from a premium IOL patient, whereas if it becomes an irregular astigmatism, these patients do not do well for a toric IOL implant. In other words, you need to have a regular orthogonal astigmatism for to plan a toric IOL implant, whereas in an early keratoconus patients who comes in for a desirous to toric IOL implant, we need to be very clear with him that either we can do a topo-guided surface regularization and then do a toric IOL implant, or you need to tell him that you are only going to debulk the toricity of the eye and maybe improve the quality of vision, but you cannot promise him a premium vision. We now have the very latest formulas which have evolved, the generations which have come in, and the Barretts now, the Barrett and the Olsen and the Hill RBF are in a position wherein they are able to not just measure a normal anterior segment, but also measure all axial length to a small anophthalmic eye to a very large myopic eye. So the 5th generation formulae which have come have all the data which are necessary to give us the precise answers which we need. So the Barrett Universal 2 formulae, which has now the one other important advantage which it has is, it also accounts for the varying principal plane among the different part IOLs. In other words, a low hyperopic eye with a low positive meniscus lens to a negative lens is also taken into account, and keeping this into account, you are getting more accurate in your measurement of your effective lens position. The process of astigmatic correction is even more. It needs a preoperative attention to not just measuring the corneal astigmatism, but accurately using the right formulae to plan a toric IOL implant. It needs intraoperative attention to ensure that we use the right kind of device to mark, to align the toric IOL and lock it into its final position on the surgical platform. And we need to have all the strategies which help us in post-operatively addressing the amount of residual astigmatism, so that you send your patients as happy as you have promised him in the initial sitting. So the marker challenges are, you could do a freehand marking with your patient sitting upright up to overcome the cyclorotation. But probably the more accurate ways to go would be to use the horizontal beam of the slit lamp and measure the 3 o'clock, 9 o'clock positions, or you could use your bubble markers to achieve this, or you could use a Mendelssohn's marker to go back intraoperatively to ensure that the 3 o'clock, 9 o'clock positions are okay, and then use a toric axis marker for the particular axis on which the IOL is going to be finally aligned. Or you could use your Varion imaging device, wherein after the intraocular lens is implanted, after your intraocular lens is implanted, you could get your overlay, what is happening? The overlay would come in, which would, I'm sure you are able to see it, which helps you lock the intraocular lens into its final position after the viscoelastic is completely emptied and the IOL is ensured it's nudged onto the posterior capsule and locked into the final position. The causes of dissatisfaction could actually be clubbed into these 6 C's. A small amount of residual refractive error or a cylindrical part, or if there's a posterior corneal opacity which needs to be addressed after a wait of 3 months to ensure that you give the right size opening. We need to look into the ocular surface. We need to see there is no cystoid macular edema which was pre-existent or which is there, which could be the causative factor for the drop in quality of vision. We need to ensure that the IOL is well centered, and most importantly, we need to find out whether this patient is with over expectations which has to be toned down, and maybe a greater amount of chair time is necessary. So talking about dealing with the refractive surprises, which is the next part of my talk. One is all of which I discussed with you all along as to how you prevent a refractive surprise by being extremely accurate in each of these measurement steps. Or if it's a very small amount of refractive error, you could probably, some of these patients are so happy that just prescription of glasses to be occasionally worn would suffice. But some of these patients would need each of these, which I would try to address. Like when it comes to a residual refractive error following a toric IOL, more often than not, it is that the toric IOL has rotated and it's not in its position. So if you know that the cause of the residual refractive error is because of the rotation of the toric IOL, we can go ahead and solve this position. So it becomes necessary that we see these patients not just immediately post-op, but even within a couple of weeks, and see finally what is the rotation of the IOL, which is not a very common incidence at all. And if so, you measure three things. You measure the manifest refraction, the amount of astigmatism and the axis, and you could enter it on the astigmaticfix.com and it would tell you how much is the rotation which is needed. You could use the Bardal and Harden toric IOL calculator results, which would tell us what is the axis where you need to finally reposition your IOL, and then what would be the residual refractive error which would happen even after the placement. Or today we have the Barrett RX formulae, which gives us even precise information. It tells us how much to rotate the toric IOL if necessary. It tells us whether this could be adjusted by just adjusting the spherical and the toric part, or it tells us that whether this patient needs a piggy bag IOL. Like in this situation wherein those imaging devices are not there, you could just mark the axis. It has told us that in this particular case it had to be repositioned in 60 degrees, and then and after pre-play marking the eye, you are able to, just with the infusion on and without any use of viscoelastic, you are able to lock into this position. It could also be that if you have a Varion device, the image overlay comes in, and here the implantation axis is 174 and not what it was. So you need to just open up the incisions, and then with the infusion on, you could just reposition it on the required axis and lock it into this position. It could be that the rotation of the IOL is not the reason for the residual refractive error, wherein then you could use a Mendelssohn marker and mark the 3 o'clock and 9 o'clock, and then also the cord lengths. Essentially, when you are doing a limbal LRI, you need to have different nomograms which are available, which you have experience with, which will, based on the amount of astigmatism, which will tell you whether you need to make a 1 arcuate incision or a 2 arcuate incision. You could even use imaging devices, which would makes it even more easy to measure the exact cord length and then pre-place our incisions. Or you could have a femtocataract platform, which would help you to exactly place your arcuates. You could use your LASIK device to correct the residual refractive error by using a microkeratome incision, or you could use, if the corneal thickness is not adequate, you could do a transepithelial PRK and treat the small amount of residual power. Essentially, some of these small steps, if it is done, if the patient has a residual refractive error, they would be most happy with these kind of solutions. But we need to be cognizant of the fact that some of these patients all of these patients are older patients, and they already have a baseline dry eye disease. So we need to be very sure that these residual refractive errors is something the patient is seeking to be treated, and go ahead and treat. If the amount of astigmatism is more, you could place a piggy bag IOL in these eyes. Today we have the Sulcoflex lenses with the undulating haptics, which can be placed in the ciliary sulcus. And essentially, what we most importantly need to know, that these IOLs have to be positioned so that the axis at right angles, the haptics are at right angles to the way the original IOL was placed, and they have a posterior concavity, which would ensure that the two lens surfaces are not stuck to each other, and there is no interlenticular fibrosis. And in an extreme situation where the IOL has been totally wrong, we need to decide that we need to do an IOL exchange. So even that is quite simple. We need to just hold on to the haptic of the IOL and then just bisect it. We need not bisect it all the way. We need to, of course, ensure that the viscoelastic is adequate, and you could just get the lenses out as has been shown to you, and then go ahead and position another IOL of the right part and bail the patient out of this problem. YAG capsulectomy, as I had already said, is something, if there is a PCO, you need to make an adequate size opening, but you need to be clear that you are not thinking of an IOL exchange at a later date, because you would have taken away the posterior capsule support altogether. It could be that something as simple as the diffractive rings of the multifocal IOL has not been positioned appropriately, and sometimes just a simple intervention in the immediate post-operative period of just recentering and the lens would be all that is necessary. We need to be cognizant that there are certain optical challenges, like if an eye has a large angle kappa or a large angle alpha, these eyes should not be taken for a premium IOL implant, and for this we have the eye trace and the other devices which tell us. And something what we need to remember, at any value of more than 0.5 angle alpha or angle kappa are not ideal candidates for a multifocal IOL implant, because the optical alignment is not accurate. There is this theoretical possibility of doing a laser iridoplasty to recenter, so that you are able to retract the iris tissue to expose more rings. And this is a case wherein the patient came with a decentered multifocal IOL, and on opening up the incision and trying to readjust, it found that the haptic of the IOL was actually broken. And as you can see, so all that you need to do is just remove this IOL and place another IOL. We need to be cognizant that some of these patients could have dysphotoptic symptoms which need to be addressed, and this was well alluded to by Dr. Ramamurthy in his talk, because we need to understand that multifocality is not a physiological condition, and some of these patients do settle down with neuroadaptation, and in an extreme situation negative dysphotopsia could be treated with a secondary piggyback IOL. We need to understand that multifocality is a trade-off to spectacle independence with dysphotopsia, and these have to be extremely well balanced. Some of these simple remedial measures is like putting a pilocarpine eye drops in the evening before the patient goes on a long drive, or keeping the dome lights of the car on, or treating these small residual errors is all that is needed, and IOL exchange is probably the last thing which is to be kept in view, but that might have to be resorted to. Last but not the least, the post-operative regime has to be kept in mind that the regimen is as simple as is possible. We actually use Vigadexa for just 2 weeks and treat the patient with Nevanac for 6 weeks, and plenty of artificial tears which is carried out. And if in a multifocal eye, you could do a micro monovision treatment by titrating the results of the second eye. Paucity of time, I am not going to be going into the details of all of these. But what is most important for all of us to take in mind is that finally, before you address all that you have with your patients, what you need is that extra chair time to let the patient know that you are very concerned with the patient's problem, and if you deal with it, you are probably already on the road to having a more satisfied patient.